Hello and welcome to the Virtual Clinical Podcast. I am joined today with Megan Swope. Megan is a nurse that I kind of work with a little teeny bit, little baby bit, at the current place that I work now. Megan has a storied career that I'm excited to talk to you guys about, most notably her work with the Period Project of Harrisburg. And I can't wait to get into all the details about how she started her nonprofit, where she's been as a nurse, her starting as a nurse. This is episode 2 or 3 of season 5 of the Virtual Clinical Podcast. Took a little bit of a break, but now we're back. Megan, welcome to the podcast.
Thank you so much, and thanks for having me.
Absolutely. So I love going over people's resumes because I love digging into details about themselves. So tell us why you decided to become a nurse.
I feel like I was born into it. My dad was a doctor and my mom was a nurse, and my mom even came from a lineage of nurses. Her aunt was the first dean of nursing at Villanova, and my mom was in the first class of nurses to receive their BSN at Villanova. I
Wow.
did not have the grades to go to Villanova, but followed in their footsteps and went to Geisinger Medical Center School of Nursing. And it was just always, I can't remember a time when I wasn't playing with my dolls, patching them up and, taking care of them. It was just always something that was in my blood. I remember working in my dad's office growing up. So it's really been a part of my life as long as I can remember.
That's amazing. I also would like to comment, if I can, that I don't know, you mentioned that you didn't have the grades to go to Villanova, but I have met people that have gone to these diploma programs and it's difficult. Like these programs are challenging. So I don't want to discredit anybody or yourself, right? Because becoming a nurse at these diploma programs is tough.
It is. And, I left for college right out of high school. Um, and I'm just going to be honest, I met a guy. It didn't end well, failed out of school. So by the time I went to Geisinger, I had to sell myself a little bit. I had gone to community college. So I was making my way to figuring things out and got into a program that was very challenging. And it by no means was easy for me, but I was committed and I was determined. And the quality of the professors in the program was incredibly demanding, but really high quality education that I received there. And when I came out of that program, our last, I guess they were called trimesters, I had a full assignment of 6 patients, that I was taking care of. By the time I got to Holy Spirit and I was thrown into it, it didn't faze me because I had such great clinical experience. So I have to say that I credit that program with
Yeah.
a great start to my career.
That's amazing. I also find commonality right now because I fed out of nursing school as well. I had a bit of a different pathway, but my pathway was more I wanted to be a Division 1 athlete and that's it, right? And then I had an undiagnosed disorder of ADHD. And the struggle's real. I think that you bring up such a great point of determination, never giving up, because nursing school
Hmm.
is for a lot of people, right? And if you have the grit, you can do anything.
Hmm.
And I also love that you got thrown into a 6-patient assignment so that you were like literally were not scared to take care of patients right off the bat.
Yeah.
Geisinger is a bit of a distance from Holy Spirit on the map. What was your first job like? Were you nervous at all? Like I know you weren't nervous taking care of patients, but was that a moment where you're like, okay, I am the person taking care of this patient now. This is what it is. Or was it something else?
I mean,
Sorry.
there's always a bit of terror. I mean, I think when you're in your first job, it was a telemetry unit, and I had about a week of orientation where somebody was, precepting me, and then it was kind of like you're on your own. Um, and I remember every Christmas, I remember this experience because I have an ornament on my tree from the first patient I had that went down the tubes on me, and she was bleeding out at following an ERCP. And
Wow.
when I say bleeding out, I mean graduates of Frank
Yep.
blood.
Yep.
And I remember there was an LPN, I'll just say her first name, Anne, who stood with me and helped me navigate through that whole situation. And I remember praying with this patient because she was certain that this was the end of her life. And it was at that moment I decided to go back to the MICU because I realized, I don't have the skill set. I don't know, you know, I want to learn more and I want to grow in my career so that when this happens again, I am fully prepared and confident in advanced life support so that I can you know be more confident in who I am. Even though I was in my first year of nursing, I knew there was so much more to learn, and I was hungry for it. And I spent the next 5 years after that in the MICU. Um, but I think of her every year because I have the ornament.
Yeah, no, sorry, I'm a loss for words right now because of the detail of that story and what it means for a patient to kind of say that those words to you, and also for you to be that caring person next to them. I think that that's just one of those things that I try to explain to my nursing students all the time. I'm like, this is what it is. You know, the way that people describe things sometimes in books is not always what it presents itself in real life. And just thankful that, you have these experiences that you can share. And MICU is a tough place. That was kind of like my other thought as well. MICU is one of those units that people are sick. And it's sick in terms of you have 40 comorbidities, right? And not one right. And not one thing that we're going to do for them fixes the other thing. It's a fine battle, almost like a tightrope dance of keeping the patient safe and taking
Mhm.
care of them. So after your MICU journey, you then became a director of nursing, correct?
Well, I actually spent 10 years at Holy Spirit. I was in the MICU for 5 years and then the ER for four. And then I actually did leave. I remained active in nursing more on a PRN basis, and focused on raising our two children. So I had a little bit of sabbatical from nursing, and got
And we all
into
need
direct
sometimes too.
sales. Yeah,
Oh, that's great.
I was a direct sales business person for a number of years. But I always kept my license, and I always kind of came back, did some agency and things like that. But when I returned full time, I was a director of nursing and long term care, assistant director and director of nursing.
So I kind of want to go back to the direct sales part because I do find
Hmm.
commonalities in the customer service aspect of direct sales and patient care. And there's a lot of nurses out there that may want to go into some sort of sales. I can think of medical sales,
Hmm.
for a medical rep company. You're an educator for them or something. Did you find it as an easy transition to go into a direct sales position, or was that a bit more challenging, and were there things that you had to, like, learn on the fly? Tell me about that process for you.
You know, I think the skills that we use every day at the bedside and the communication, the active listening, all of those things are things you use in the world outside and vice versa. So 100% I would say that I used my nursing. And honestly, you can't put it down. So, you're out and you look at someone and you're like, they've got a little JVD, they've got a little, like ankle edema. You're like, you're not trying to diagnose anyone, but you're like, you might want to go see your doctor. So you can never completely put it down when you're out. I may be there to give them a makeover, but I can't help myself, but notice they are tripoding, and you might want to see your doctor soon. But I think it's just in the fabric of who you are. um, but it's very, I think nurses do find that they're drawn to opportunities. And also, it's a great way to express yourself outside your nursing career. Just doing something different that's kind of just for you in that respect. Um, it can be very satisfying and give you a little bit of an outlet too.
Yeah, that's awesome. That is a good thing to think about, is the outlet outside of nursing, but still remains current in skill. I think I find
Hmm.
parallels to that myself by joining a lot of things that are kind of in healthcare. I've done a lot of us like volunteer work with different associations, or just kind of talking to other nurses in the profession outside of this podcast,
Hmm.
even, and just kind of being involved, but not really like involved. And I think that that's helped reduce burnout for me in a way,
Hmm.
something that doesn't, drive bleeding out, right? And like the burnout that could be from that and those patients that you deal with, but
Hmm.
still keeps you relevant to, the issues that exist, and also finding commonality in uncommon spaces. So then you've returned as a director of nursing in the long-term care facility. What was the decision to return, maybe not as a staff nurse, but more in like a leadership realm? Did you find yourself, more of a, I think I could do this, but a leader? Was there any kind of trepidation? Did you always see yourself as a leader?
Well, because I was in leadership in the direct sales, what I found was that recruiters were calling me about the possibility of working in long-term care, and I had done a little bit agency-wise and been approached about being. I have been an assistant director of nursing. When you're a director of nursing, you're really running a small community. That's what a long-term care facility is. You're one part HR, one part um, regulatory compliance, one part risk management. And so there's all those hats that you're wearing, quality assurance. Um, so, public relations. So there's all those things that it requires to be successful at that. And so I think my background in business helped me look at it as how can I make this facility be as successful as possible. And I think that's, and I really enjoyed the population a lot. What I found was who you work for is critically important. Unfortunately, I didn't work for the right organizations. I believe they're out there. I just wasn't a good fit for me. And I was working for an agency when that's where I was when a mentor that we share found me and was like, "Hey, would you ever consider?" And I said yes to come back into acute care nursing.
Yeah, people say that they quit poor leadership. They don't quit their coworkers or the people that they serve. And I think that that's such a valuable lesson, because I think I mean, long-term care, for example, is one of the more difficult spaces, I think, to be a leader in. You are one of one, oftentimes, as you described. You have many roles that you need to play, and oftentimes, if they're in certain like places, you are often the staffing solution to any kind of shortages that might exist. And I think that that is just crazy. In my personal opinion, there needs to be more legislation around things like that, that you can kind of make these facilities, much better. But that's neither here nor there. So left there, and then and then this is where I think I met you, was sometime during the pandemic, maybe, right?
Hmm.
You came up to my unit and you were like, "Hey, I'm this person," and I'm like, "Hey, great, love that." You took a job in peri anesthesia,
I
and
did.
and that's a different role from how you describe the beginning of your career, sicu MICU in the ED, and then as a director. So
Hmm.
was that more of a career choice for the patient population, or was it more a career choice for other reasons?
I was, just to paint the picture, I was a nurse manager of a 55-bed dementia unit
Wow.
in the start of COVID.
That's right, I do
So
see that. I'm sorry, I forgot
I
about
didn't
that.
care what she was offering me. I was headed out. No. Um, I had worked in outpatient surgery before for about a year at Holy Spirit. It wasn't really my gig. I couldn't get myself as worked up over some of the things. Like when you go from critical care to that department and they want the chart to be in a certain order, and you're like, that is not a top priority for me. I just couldn't align my, get yourself worked up at the time. Um, but I knew I could do the job. I will be honest with you. I hadn't been at the bedside in so long.
Yeah,
And it was COVID.
right, right.
I'm now 50 years old. I'm in school for my BSN because I saw it coming. So I was
Yes.
finished. I was about between 6 and 9 months into the 12 months that I needed. and I'm coming in hot on Hershey orientation. Oh, sorry. Um, it's a 12-week orientation, and then I was going to night shifts. So I hadn't done a lot of those skills in a number of years. So it was one of the most challenging seasons I'll ever experience, I think, professionally. Um, to work at the pace, at the levels, at the skill level of my peers.
Mhm.
Um, as you know, the PACU is quite busy.
It's really busy.
Um, it's really
Yeah.
busy,
Yeah.
and here I am trotting in. So, and I remember the day I met you. I know where you were sitting. I don't know why that just stays in my head. And
Same.
I will never forget that 5 days in that unit. To this day, I talk about it because I wanted to genuflect in front of those nurses. I still do. I don't know how they do it.
Mhm.
You, I, I was just trying to help them in any way I could while I was up there. I'm like, what can
Yeah.
I do? I was turning people. I was doing whatever I could. There was no observing for me. I was like hands on.
No. It's so hard.
It's, it's unbelievably difficult unit, and the nurses are head and shoulders above. Just I have the highest respect for those nurses. So um, that experience helped me immensely being up there, even just for a few days. And also, I had no idea that I'd be in the position I'm in now, and I still pull on that experience today.
That's amazing. I'm gonna pass it along to some of the colleagues that are still there, um, because I think that that's important that we know those things, right? Because we don't often hear
Mm,
feedback from folks that have been on the unit observing for 5 days and what the experience meant to them, especially in such a busy unit.
hmm
And for folks listening, this is a 31 bed neurocritical care unit that is exceptionally busy all the time. There's never a dull moment, in my opinion. There may be lulls, but for the most part, it is one of the busiest units that I have ever been a part of. And I'm biased because I've been there for so long, but I've heard other people come and also comment, from other units around even the nation that it's a different thing to them. And that's kind of exciting to me. But yeah, I still remember the day that you came to the unit and I my brain is on a different timeline all the time. So so I thought it was way before the pandemic. I was like, "Oh, this was like 2018 that I remember meeting Megan." No, it's like during the pandemic 2020. I just had a different perception of it, probably because I wasn't running around in COVID outfit all day long. I was on
hmm
my unit and not knowing probably like what we were doing that day because everything is just busy all the time. But anywho, I do want to go back really quickly because I did want to talk
hmm
about another position of yours. And not a lot of people go into it, at least not a lot of people that I've met, but you held a role of utilization management. And I
hmm
mentioned that role because I would like you to kind of discuss what utilization management is for nurses listening because there are prominent roles in this field, but I've never had somebody who actually held a role in it. So if you could just discuss what that role was for a bit, that'd be awesome.
Well, it may not be exactly what you're thinking, but it was a contract role, and my in my capacity, I worked for the Commonwealth of Pennsylvania um, for the Office of Long-Term Living. So this was a job that was limited to a few months, but basically what I did was because of my long-term care experience, they hired me to go out and complete what are called level two passer reviews. So this is looking at individuals with mental health diagnoses that are in long-term care facilities and what resources they may need to be put into place to complete their plan of care. I also would do OBRA reviews, different reviews of the chart to make sure that uh, regulations are being met. Um, and basically, it was mainly in the Harrisburg area. We would go into Lancaster, Dauphin, Cumberland County and complete the reviews. It wasn't exactly the same as utilization management in the hospital where you're making decisions about admission. things like that.
Yeah, I do think though that so I've met some utilization managers, maybe not in our hospital, but that have done chart reviews.
Hmm.
And for instance, make sure that the diagnosis codes are correct. And
Hmm.
make sure
Yes.
that when a physician or provider writes a note about something or wants to put like their past medical history in for those that
Hmm.
are kind of
Hmm.
familiar with charts, that we are capturing that data accurately. And even in like the description that you said with like, you're out in the field making sure that their charts are good, still reflects payment that is going to come
Hmm.
back to the provider
Yeah.
and or the company that's kind of representing that patient at the time.
Hmm.
And that's really important for folks that are maybe interested in going on to being a nurse manager, maybe getting their MBA at some point, knowing where your costs are coming from, how you're
Hmm.
capturing those things. I think really resonates, at least from what I discussed in my post clinical. I'm not like a lot of other clinical instructors, but I do hit on the point that a lot of things matter, and utilization management is one of them.
Hmm. I would totally agree, and I think sometimes we from everything from what you just mentioned to the pharmacological, requirements, they for a drug to be appropriate or paid for, there has to be a diagnosis that's
Mhm.
associated with it. We see that a lot in the long-term care facilities. There won't be a diagnosis of depression, yet there's an antidepressant ordered, so and it won't be paid for, and they'll kick it back and things like that. So as an RN in that setting, you have to be mindful of making sure that the ICD-10 codes
Yes.
match up. As you're admitting a patient, those type of things come into play.
Yeah. That's very important. So then you I think went back to dispatch health. I don't know what dispatch health is, but it sounds exciting to me anyways. Every time it's
Oh,
right.
it was. Yes.
So tell me about that journey because I do also want to bring up the fact that role names, so director, manager, things like that can mean the same things and also different things depending on where you work. So for example, the
Hmm.
director role at the long-term care facility can be similar in responsibility and scope as a manager of a unit. It's just how they kind of determine things in some fashions. So was
Hmm.
this kind of like that? Was this different like that? Describe that role for us.
The role of senior nurse manager reported directly to the CMO of Dispatch Health. So, um, but I will tell you, it was a national healthcare company, startup that is out of Denver, and they basically were attempting to revolutionize delivery of care, take urgent care. Aren't we all? Um,
Oh,
Um, we're just constantly trying to revolutionize. But take urgent care into the home. And what we would do is I was managing the telephonic triage team, and it was about 50 nurses and an additional 50 medical assistants. And so the nurses would take calls that do a telephonic triage assessment from 54 markets across the country, and then determine if the patient it was immense, um, and then determine if the patient could wait till one of our PAs or nurse practitioners could come out to them in their home and see them. And we could do everything in the home from EKGs, chest X-ray could come to them in the home. They would do IV fluid, antibiotics, but we would also do kind of like hospital at home. In addition, we had two different divisions. And so that was my role. My role was, hiring, training, maintenance, administration of those two divisions. And during my tenure, I had more employees than any other leader in the company. It was just a really large responsibility.
that it's amazing. I want to hit really quickly. You said something that just resonated so much with a lot of LinkedIn job descriptions that I see, in that a lot of companies want to revolutionize health. And companies, I laugh because critical thinking is really important here. A lot of companies claim that they're going to revolutionize health. And the fact of the matter is, in my opinion, it all comes back to basics and just providing simple care to patients. There's nothing revolutionary about it. I want to harp on a little bit of like these new AI companies coming out with things. I love AI.
Mm-hmm.
I think it has a lot of
Mm-hmm.
promise for very specific things. I don't think AI is the solution for everything because you still need a human touch. But people who are looking into maybe getting into other companies and things like that outside the hospital, just be mindful that revolutionizing healthcare is just talking to a person about their health and helping them get to what they need and the resources that are
Mm-hmm.
needed and helping them, get to tomorrow sometimes. So thank you for that because I really do love that you see the same thing that I have as well. And I've also lived the experience.
I think the thing that AI brings us is as the population grows and as the demand for care increases and as the sheer volume explodes, AI allows us to handle large volumes of data
Mhm.
quickly
Yep.
and can filter in a manner that no human could possibly. No human can look at 240 data points and see a trend. Can't do
Correct.
it. Cannot do it. And that's where things like what the department I work in, um, you know, can be helpful. It is also, in my opinion, not helpful without the human
Right.
taking that information and deciding whether or not it's important in the clinical picture. So it's relevant and it's useful, but it may not be purposeful in the end result of what's happening. So I think you know it's the idea of virtual care is not going anywhere because with the sheer volume and is it's just not going to go anywhere. Having said that, it should be viewed as a supportive adjunct
Yes.
to the bedside to prevent burnout because it's simply impossible for the bedside nurse to get it all done. And if the right people are in place, like from my perspective, um, I I've been there not being able to do it all. So I want to help the people who can't do it all because it's physically impossible, make their life easier.
Yeah. Absolutely. I have done my DMP work on the notion of our health portals and not one health portal in specific, just health portals. And I
Mm-hmm.
wanted to know, so I created a map where you could see stroke risk and modified Rankin score after your stroke and mapped it out in a nice little map. And then I layered on the broadband availability to these patients, found glaring holes, and then asked
Mm-hmm.
myself, does this matter? Right? And for people who are watching and listening, to bring it into a perspective, I was a staff nurse at this time when I was starting my DMP program, pandemic, like middle of the pandemic. And we were going to the bedside, not myself, but people, and we were assessing and I shouldn't even say assessing, we were just going in and saying, hey, we're going to get you set up for your virtual appointment. Not ever asking the question if they ever had a computer at home or if they were able to even use a phone, cell phone, smartphone, whatever it may be. And if they had a smartphone, if they even utilized it as a smartphone, which I know is mind bending to a
Mm-hmm.
lot of people because for many, it's an ingrained part of our culture to have a smartphone, right? But for folks that are, probably, I'm just generalizing here, generally living in a rural area that may not have the
Mm-hmm.
best cell service, probably don't have a smartphone, right? And one of the things that I found was that we don't assess our telehealth knowledge or even our health tech literacy, I should say, for people. And all it took or currently takes, right, is that person to go in and bring that human touch to them and ask the question, hey, is this possible for you? Right? When you mentioned virtual health, And so a lot of units have virtual ICUs. I think it's a great addition to an ICU. There's a lot of barriers sometimes to fully implementing it, and that's not just one place. I have a colleague out in California who has similar issues with people adopting virtual ICU in the true meaning
Mm-hmm.
of it. But the point where you're trying to analyze 220 points of data, and it can do it in like 0.5 seconds. That is the part where
Mm-hmm.
AI is so beneficial, like you're mentioning, right? Can we look at this patient and say, hey, something's going to happen. We're not sure what. Oftentimes we might already know something might happen, right, with our clinical judgment skills. But what if we had another set of eyes on it that could help take a look into it too, right? And then I love that you mentioned that you still need a human. You still need a human. There's units out there like the neuroscience unit that I mentioned before that if you could predict anything that to happen with a neuroscience patient, I think that you'd be able to predict a lot of other things because
Mm-hmm.
because what's happening in the brain and what's happening in the body is not always translatable to what's captured in the charting system. And
Mm-hmm.
it's difficult sometimes to really predict based on them not moving or some sort of, neurodecline that something's going to happen. And hopefully we get there with the tele ICU environment as well.
Mm-hmm. I've actually asked if we could work on who a predictor for neurological decline, being that we're a level one trauma center,
Mhm.
um, with a very busy. So I know that that's in out there, um, but I think oftentimes in the ICU setting, these types of predictors aren't that useful because we already know, the
Yeah.
nurses are well aware.
Yeah.
In the med surge,
Yes.
we don't have the monitoring. They're not on the monitor, so we don't have the data. But in the intermediate care in the ER, um, it can be extremely helpful. And that's kind of what we've seen, um, because the nurse to patient ratio is not what it is. When it's one on one or two on patients to one nurse, they're not going to miss,
Mhm.
the opportunity. They're going to be in the rooms. When a patient to nurse ratio is higher and they just physically are not observing the patient as frequently, um, we may see something, and be able to intervene. Um, and I think those opportunities, are exciting
Yeah.
because we're able to make, that impact. And I think eventually in the ICU units, the patients that are IMC or, that maybe are on that edge, the
Mhm.
nurses
Yes.
will get to the point where they're like, hey, this person's doing better, but could you, while we can't visually observe them like teleobs does, teleobs is a completely different division, we can involve them in the care plan of care, like, and still be involved and keep an eye on vital signs or pain assessments or whatever the nurse needs, so that can free her up, um,
Yeah.
because that certainly gives her more time to do other things.
Yeah. I think that's yes. So my mind is buzzing right now if you couldn't tell. So for those listening and watching, IMC, it might not exist in all hospitals. So sometimes you have intensive care units that are solely intensive care patients only. And then you have acute care floors where some hospitals and units just downgrade right to the acute care floor and they're just considered acute care. So they're probably like floor status and they may not have an intermediate care unit. Some hospitals do have an intermediate care, which is kind of in between ICU and floor status. However, there's a caveat to it. They are usually still pretty sick. They just don't require ICU level care for the things
Hmm.
that the ICU does, like Q1 hour vital signs and assessments and things like that. And those patients, especially the ED as well, are such high risk patients that anything can happen at any given time because they're in that flux between ICU and floor
Hmm.
or ED and a unit. So I think that's a great point to make is that, virtual ICUs and virtual care can really impact those units really well.
I think that it's much easier on our software, on our what is it called? I can't think of the word right now. On our whatever it is.
Platform?
It's called Clue, but I can't, platform, thank you.
Yeah, you're welcome.
Is we can trend blood pressure, heart rate. Like we can literally look over the last 12 hours at each data point. What has it been? It's much easier on our platform than in the Philips. So we can literally, if somebody just wants to know what has the map been, for the last this period of time, it's much easier for us to look at that and say, hey, this is what's going on than it is for the nurse to do that. So, or for us to pop in, because we do have the cameras and we can visually see, okay, what's happening right now, or, we can literally say every morning it seems to be lower, whatever the case might be. It's easier for us to do that than for the bedside.
Yeah, that's awesome. Okay, now
Okay.
I'm going to transition a little bit. So
Okay.
when I first met you as well on the unit that you were doing your 5 days, you were very passionate about this nonprofit. And
Yes.
the nonprofit is the Period Project of Harrisburg. And I was blown away, number one, by the drive you had to create a nonprofit, just simply put. And number two, that there was such a period poverty happening where I lived. And number three, that there was something that people could do about it. So take me back to the beginning for right now about where this came from and how you started to develop this idea.
Well, I was in my last class for my BSN, and my capstone required me to come up with a change project. And I was looking up ideas, and one I came across or began to kind of develop was um, to do a community health initiative. And I came across the term period poverty. And to be honest, I wasn't familiar with it. And I thought, how can I, as a woman, as somebody that's menstruated for decades, how would I not know really what this means? So I started to look into it more, and I watched a video called How Do Homeless Women Deal with Their Periods? And I was
Yeah.
transfixed. Um, just looking at what it would be like to be unhoused, unsheltered, and have to navigate your menstrual hygiene. And I began to think this is such a solvable issue. And as I began to realize that your Medicaid funds or your EBT card can't be used to purchase your menstrual
Really?
hygiene products, it is illegal because it is a federally subsidized program. Regardless of what the state says, Medicare or the federal government says you cannot use your card to buy the products. So as a result, um, you can buy, a bandage for your arm if you're bleeding from your arm. But can you still hear me okay? Because my one
Yeah, yeah,
ear,
yeah.
okay,
Yep.
good. My one ear thing died. As a result, you can buy a bandage for your arm, but if you're bleeding elsewhere, it's not covered. So I was outraged. So I called Ashley Visco, who is the director of community health outreach, and asked her a little bit more in-depth questions about the community health assessment that Penn State Health had done. She gave me some great data, and when I shared my idea, she said, that's a great idea, and if you really wanted to do that for real, you could apply for the community health grant.
Hmm.
And I'm like, okay. So I applied for the grant, didn't know what I was doing,
I love
and I got it. And I got it. So next thing I knew, I was putting together a what I call Day of Impact. And in March of 2021, I got 25 volunteers together at the Girl Scouts in the heart of PA, and we put together period packs. And I have to say, the marketing department of Penn State Health provided the bags that we put them in, and we created 1,500 period packs, which were to be given through free clinics in the city to the unsheltered and low income. We used Beacon Clinic for Hope and Healing to distribute those, and they have been a partner ever since. They are incredible. Deb McLean is the executive director and is a fierce supporter of us. Um, and it was a big hit, and people got so excited. They're like, when are we doing this again? And I'm like, I have no idea. I'm thinking inside. But I began to realize nobody at that time, to my knowledge, was doing this. And I was getting so much encouragement, I decided to become a nonprofit. We filed for state status that summer and then became a 501c3 a few months after that. In the meantime, I knew I was moving, so I knew it would be a little bit of a challenge, but I established a strong board and also was blessed to receive the Association of Friends and Family of the College of Medicine grant, which helped fuel our work the next year. In 2023, we received a number of grants that I applied for, which really helped us grow immensely. And we continue to grow. Every year we've doubled or tripled our growth since that time.
Wow. So, was it difficult to apply to the state and federally for the nonprofit status? Like, did you have to like were there a lot of hoops? Did you have to do so did you have to like prove yourself before you could like apply for a status like this? Was there any kind of like I don't know, difficulties that you could describe or was it easy and you had like a mentor that could help you through that?
I was going to say it's only as difficult because you don't know what you're doing.
Yeah.
And I have, like I have had to, I'm self-taught and like for a long time didn't write. As far as applying to be a nonprofit, it's not that difficult. And there actually are platforms that have like a package that you can apply through them and they'll take care of for one price, they'll take care of the legwork or paperwork for you. I, of course, did it the more difficult way. Um, and, for example, I didn't know, I just was naming my paper the Period Project, Harrisburg. There is a national organization called the Period Project. So when I became a 501c3, had to go by another name, which is Making Miracles Happen, Inc. And then I established a fictitious name of the Period
Period
Project
project.
Harrisburg. So both can be utilized when referring to us, but under the IRS, we are Making Miracles Happen, Inc. Um, so there were life lessons as I went that I learned. Um, and, I think a pivotal step for me in that process of being a nonprofit was the grant writing. Deb McLean once again taught me a powerful lesson. I remember talking to her and saying, I don't know how to write grants, so I'm not applying. And she's like, well, I wasn't a grant writer till I became a grant writer. And that just, and so I
Yeah,
just started writing grants and we started getting them. So,
that's amazing. I love that there was somebody to support you that first of all, I love that you said I don't know. I think that that's such a powerful tool that people can always keep with them. You don't have to know everything. And if you just own up to not knowing, but then being honest with somebody else, nine times
mhm,
out of 10, they're going to help you in some way of doing it or even like linking you up to someone else. And I've I've attempted grant writing. It can be tricky. I don't
mhm.
know. I still don't know what I'm doing half the time. And that's okay because I learn every day when I do something new. But I do find that if you have good support and this lady Deb sounds like a great support for you, can lead you in the right direction. Forming a board, you mentioned that you found a strong board. Was that an interview process? How did you find like what you consider a strong board to support you in this journey? Because you are Florida miles away. You're not like in Maryland or like in Philadelphia. You're a flight or a very long train ride away. So how was that for you?
If I'm being completely honest, it's still a one woman show in many ways. I mean,
Okay.
at the end of the day, the buck stops with
Yeah.
me.
Sure.
And, um, I think you should go into it expecting that because no one will ever be as passionate or
Okay.
committed or tireless as you because people many times say to me when they're talking to me about it, it's your vision, and it is my vision. I do see a day where we could grow it to a point where there's an executive director other than me, because there are people with far more talent than myself that professionally run organizations and would probably do a better job. Um, having said all that, my board is comprised. Naturally, you tend to gravitate towards friends, but I have friends that have board experience. So I think that's been vitally important. Also, recognizing when maybe they're not a good fit for the board, and it's time to look for resumes of people that do have more experience or more business experience, even if not board experience, for the position we're filling. For example, right now, we're establishing an executive board within our board. Up till now, it's been more of just a board of directors
Yeah,
because I need a plan of succession. Um, should something happen to me, and having an executive board is part of that.
that's awesome. I think it almost is kind of like your experiences with being a manager, knowing quote unquote your employees who are not really employees, right? Because they might, as nonprofits,
Hmm.
I've seen a lot of boards where you're paid to be on the board, and boards that it's literally just volunteerism, but it helps
Yes.
to produce such good for the community that people don't mind serving in a volunteer role. And I think that nonprofits can do such good if there's that specific problem that it's trying to serve. And I had no idea that, number one, homeless people experience poverty. You just blew my mind apart with that, you know, EBP cards, excuse me, EBT cards,
Yeah.
and Medicare won't pay for period projects, even though we can bleed from other places.
Hmm.
Kind of angers me a lot, even though I'm not
Hmm.
really angry person right now. And I watched this recent election cycle, and there was a lot of talk about putting period projects in schools and products,
Hmm.
excuse me, in schools. And I thought to myself, like, why couldn't we always do that for free, right? Like, why do I have to pay a quarter for a tampon or a feminine product or something
Hmm.
that
Hmm.
is just a bunch of cotton, right? Or something that can help me not miss class. Because a lot of what I didn't know and learned about was that folks were missing school because they didn't
Hmm.
have products. And that's kind of upsetting, right? So you shouldn't have
Yeah.
to go to school and worry about where you're getting your period projects from if you are menstruating. What does the future look like? So is there gonna be another, like, day of service event coming up here soon that I can link
Hmm.
people to? We will include the website for sure in the show notes, but is there something coming up soon that I can link people to?
Well, first, I would just mention the school connection has been huge for us. We currently support school districts like Steelton High Spire. School district has been a huge success story for us. To celebrate their growth, this nurse Joe is our contact there, and she is just a star healthcare provider. She is just amazing. Um, and really changing the narrative for menstruators that she is coming into contact with and making it a period positive place for the students. We also are supporting John Harris High School, Susquehanna Township, um, and other school districts around the area. And I will say that Governor Shapiro, we were blessed and very honored to be invited to the governor's mansion to meet with
That's
First Lady
awesome.
Shapiro
Yeah.
for a day of menstrual equity discussion with key stakeholders in May.
Wow.
And it was really to also talk about the fact that Governor Shapiro now has in all Commonwealth office buildings free supplies, but had asked for $3 million in menstrual hygiene supplies to be set aside for schools, and it was approved. However, I will say, while that is tremendous, the only schools that will see those supplies will be schools that have more than 50% of the population receiving free lunch, which means significant poverty, really
Yeah.
significant.
Yes.
So there's going to be a lot of students going to school that will never see sanitary supplies free and accessible to them. So there's much work that needs to be done to make sure that there are not students missing school. We get requests specifically with that concern quite often, and college students. We
Yes.
recently were able to make reestablish contact with Central Penn College that has a high rate, also Penn State Harrisburg, of, of students that are living below the poverty level, attending college on scholarships and grants and things, but really struggling in other ways. So those are really significant concerns there. But I think there's quite a bit of work to do in this, realm. But I think the future for us will continue, I think, to have a lot to do with schools. Food banks have been huge. We get a lot of our products out at food banks. It's an accessible place where
Yeah.
people are already going because they need other ways of support. We formed a partnership at the end of the year here with Healthy Steps Diaper Bank that also hands out sanitary supplies to moms, especially new moms that are having heavier bleeding
Yeah.
and need more supplies, and also Central Penn Food Bank. This is breaking news because I haven't announced it yet, but I'll tell you that literally thousands of dollars of products is being given to them to distribute um, this month. And I will also say we just had a day of impact, which is what we call our community day of assembly, partnering with Capital Blue Cross. We had it at their Connect store in Enola. They sponsored the day as far as having it there, and it was a great event. Our next event will probably be end of April. We'll do another community day of impact, and that we will be using part of our community health grant, which we were also given again this year by Penn State Health Community Health Outreach. So part of our grant funds will be utilized for that. So as soon as I have that data, we'll definitely get it to you.
Perfect. I love that. I have some questions because
Hmm.
there was so much there that
I know. Sorry.
it's exciting. And I'm really like I have not been a part of the Period Project, have had my own schedule going on, but I've seen the growth of this nonprofit, and I really can't say enough about it because of the
Thank
purpose
you.
it serves, right? And doing things for communities like Stilton. So you mentioned that you now partner with food banks. I was just like yesterday years old, literally, when I learned that Stilton is also a food desert. And that is really important, and I kind of thought to myself, maybe there's a connection there between what I'm learning about with food deserts and what I'm learning about with period poverty, and if there's
Hmm.
a correlation. And it seems like there is. I want to do more data digging after our episode is done. But
Hmm.
there's a lot of unique things that I think are happening in Stilton right now, people need to pay attention to. For example, what you're doing in the school district,
Hmm.
and then also how they're helping with this food desert issue with building, I think, like there's a lot of businesses that are building farms and communities that exist in buildings, but to produce food for people. And I think that there's such an opportunity as well with local churches. So, just reading about today that there's a church in my town right now that has a pretty robust food bank for people if they want to come to the pantries open specific time. One of the other things that I want to mention, BSN students are still at risk for having food poverty, which means that they're at risk for having period poverty too, is the correlation I'm making
Hmm.
right now.
Hmm. Hmm.
So I was very surprised to learn a couple years ago. I raised a lot of like, hey, what are we doing about this as a clinical instructor? I, had then calmed down when I learned that we have a pantry that is accessible and available for anyone that needs it.
Hmm.
But I'm now wondering if we carry menstrual products in there too, because there was a lot that opened up my eyes in the pandemic, and having students, opening up their homes to me virtually was a
Hmm.
big like oh moment. of like, man, they're really at risk here, right? They're opening their homes to
Hmm.
vulnerability and showing me what their life is like without a virtual background. And so I now I'm going to go back tomorrow and figure out if this has that ability in there. I don't know if you know if our College of Medicine and things like that have period products in them. If they don't, we need to have make that happen. Um,
Not with me, but
not with you,
yeah.
okay. And I also want to just really congratulate you because there's a lot to be said when a nurse, and I think nurses have the greatest power to get involved with government, whether it's being invited to the Capitol building with the governor, which is really important, or somehow impacting health policy at either a local, state, national level. That is something that I believe, that's the greatest gift of nursing is how do we impact those communities by influencing people of power and people that are voted into power. So congratulations on that too, because that I think is
Thank you.
just amazing on all levels. There's a lot of nonprofits that don't even reach that ability to do that. And I think the lesson here is you found the data to kind of support your baccalaureate project. And then you reached out to people, right? You've reached out to the community health person. And then they gave you more data to look into the problem. And you figured out the core of the problem. How do I solve one part of the problem for this
Hmm.
community here, right?
Hmm.
And then it worked out for that community. It worked out for the implementation of that too, which nurses that are even listening in from their master's or doctorate programs, that is a really important piece of your project is finding the specific
Hmm.
thing that you can make a change with. So, I mean, hats off to that too. There's so many lessons here from developing this nonprofit. People can find you at the period project hbg.com. Is that your website?
No, it's actually the Period Project Harrisburg spelled out. So the
Okay.
word
Okay.
Harrisburg.com.
Okay. Awesome.
The
And
Period
then we
Project
will
Harrisburg.
Okay. And then we will find all the information needed when you have it available to people so that people can kind of join in or they can even donate to you,
Hmm.
and raise funds and all that stuff for the schools as well because I think that's just amazing.
Yes. So we definitely always appreciate any type of donation, whether it's monetary, product donation drive. Organizations will do that. If you become aware of a school or like you were just describing, students that are at risk, you can contact us. And what you were describing is our email, which is the period project hbg@gmail.com.
It was.
You can email us and say, hey, we're aware that this is going on. These people need products. We don't ask for a lot of qualifiers as long as I can substantiate the story and connect with whoever is in need. We do prefer to go through our community partners. In other words, we don't deliver directly to the person in need. We go through a local organization because they can meet with the person, make sure their other needs are being explored and so on. But if anyone has any questions, they can certainly reach out to us.
Yeah, and I think that's such a smart move too because let's just go back to describing where you live and where your board is at. You're not having to go to people's houses, right? You've partnered with the organizations
Right.
that can do that for them because the people go to them. And that I think is a really important facet of your business model, right? Your nonprofit business model. So
Yeah.
congrats. Anything else that you
Thank
would
you.
like to bring about from the period project or anything else?
I would just close with, I really believe that anyone can do this. Anyone can make a difference. It's just taking action,
Hmm.
and making an impact.
Yeah.
You see a problem, you can make a difference in your community. You can look at it, and there's even in a small way, make an impact to improve things in your community. It doesn't have to be tackling the huge issues. It can be just giving someone their dignity.
Mm,
That is not a small thing, but it makes but it is. It's just a small, solvable problem that helps elevate people and give them the opportunity to live their lives in a dignified way.
I love that so much. Megan Swope, thank you so much for joining us on an
You're
episode of the
welcome.
Virtual Clinical Podcast. I look forward to joining you again, and we'll see you soon.
Okay, thank you.